Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Denver, Colorado.
The AOSSM meeting is a premier sports meeting conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lectures. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 8 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. Today's episode is proudly supported by Nice Recovery Systems and the Recovery Shop. Nice Recovery, renowned for its leading iceless cold compression machine, has partnered with the Recovery Shop, a premier platform for postoperative products. This collaboration ensures unparalleled patient service and access to the flagship Nice Recovery machine.
Elevate your recovery experience with the finest support and innovation at shop-recovery.net. For the Nice Recovery machine, you can see more about that unit and the innovation going on here, right in our backyard in Boulder, Colorado, at www.nicerecovery.com.
Today's episode is going to focus on rotator cuff repair, specifically the various repair constructs to address different tear patterns, when and how to best augment rotator cuff repairs, and how our present clinical data can help us counsel our patients and optimize outcomes.
We are joined today by Dr. Peter Millett, an orthopedic surgeon and partner at the Steadman Clinic in Vail, Colorado, researcher and board member at the Steadman Philippon Research Institute, and medical director for the Ski and Snowboard Club of Vail. He is also an ambassador for the US Ski and Snowboard team and a consultant for NHL Players Association and the MLB Players Association.
So without further ado, let's get to the field house. Awesome. So, Peter, thank you so much for joining us for this special live episode of the Sports Docs podcast here at the AOSSM annual meeting in Denver. Thank you for taking the time.
It's great to be here, Ashley.
Awesome.
We're so excited. Okay, so you've extensively published on the topic of rotator cuff pathology. And so, obviously both of us and everyone who listens to our show are super excited to have your expertise. One of the papers that you published was a Yellow Journal article, and it was in 2014, and it highlighted the importance of recognizing and classifying patterns in order to guide your treatment. So when you're looking at a preoperative MRI, what kind of things are you looking at, and how is that going to affect, one, your plan, and two, how you counsel people?
First of all, it's really great to be here. And that paper was important in a number of ways. One of the things I've learned is that there's a lot of different types of rotator cuff tears, and you guys are all aware of that. But at the time, I don't think people recognize that as much. And during my training and as I was learning about rotator cuffs, the thought was just pull them all over and repair them to the tuberosity. And what I learned was that that's not the best way, and recognizing those tear patterns really influences the treatment strategy and how you go about figuring out how you're going to repair it. There were some other articles. Steve Burkhart did some articles looking at tear pattern recognition, and that influenced me, as well as just doing a lot of arthroscopic rotator cuff tears. So some of the things that we look at are on the MRI are the medial to lateral dimension, but we also are really kind of diligent about looking at the sagittal oblique MRI and seeing how wide it is, because sometimes you'll see a tear that looks really big on the coronal view and you think it's a massive tear, but then you look at the sagittal oblique view and it's not that big a tear. So most of the tears don't retract purely from lateral to medial. They retract sort of from anterolateral to posterolateral, and I think recognizing that and identifying that preoperatively and then intraoperatively really dictates how the repair is going to go.
Yeah. Absolutely.
Can you talk a little bit about, you kind of mentioned it, but in terms of the different tear patterns and how that changes your repair construct? So if you have like a massive U, or if you have an L-shaped tear, kind of what are you doing first in the surgery to make your repair easier rather than just dragging it over immediately or laterally and tacking it down?
Yeah, I think the preparation is probably 90% of the surgery. The actually putting the anchors in and putting it through the tendon is the easy part. So I spent a lot of time removing all the bursa, doing all the bony work that I'm going to do, and then looking at the tear. And I always look at it from posteriorly and laterally. I usually look at it, I make 2 lateral portals, so I look at it from anterolateral and posterolateral. I put a grasper on it. I figure out where the tear goes. I try and look at the fibers of the supraspinatus and try and line them up so that they're going in the appropriate direction. I look at the infraspinatus, which usually has a little bit of a shorter tendon, make sure that that's coming around where it belongs. Sometimes the infraspinatus will really wrap all the way around the greater tuberosity. There were some studies that looked at the anatomy of that showed that. And so I really spend a lot of time understanding the tear pattern. And then once I have that figured out, then that really dictates how I'm going to repair it.
Makes sense.
Yeah, I think, as a former fellow, you really taught us a lot about you have to get your preparation right to start, because you can't just sort of do a little prep, start your work, and then realize, I didn't do enough prep. You start to get in this little bit of a domino where everything starts to go, get harder.
Yeah, especially on the bigger tears too, where you're going to be spending a little more time. As the shoulder swells up, the deltoid and the bursa all sort of creep in on you. So if you do a good job clearing that out and then preserving the deep deltoid fascia, you can have more time to actually visualize it and then do the repair. And for a standard crescent-shaped tear, it's easy to just pull it over. For an L-shaped tear, you're going to do some type of footprint repair with side-to-side for the intervals, whether it's reverse L or standard L. And then for a U-shaped tear, you're going to typically do some type of mobilize everything you can. If you can pull it over, you can sometimes do a footprint repair, but sometimes you have to just do a side-to-side type of closure and and margin convergence and those types of tear patterns.
Mm-hmm. Yeah, and I think the other that reminds me too, as far as portal placement, just making sure taking your time with that, so that when you are doing these visualizations and assessing things, that you're not sort of, I'm just trying to peek around a corner and I don't really actually have a great view of it. It's just so important to take that time early on before you move forward.
Yeah, exactly, Catherine.
Can you talk a little bit about some tips and tricks for mobilization? Because we hear about interval slide, anterior, posterior, but what are you doing once you've done all your kind of visualization? What are you doing to really get that really retracted cuff tear mobilized?
That's a good question.
I think there are some tears that no matter how much you mobilize them or do releases, they just aren't going to be repairable. But I would say that probably most tears you can do enough mobilization to get them repaired over the footprint or close. And what I usually do is I'll do my bursectomy, I'll pull on the tear, and then I'll usually put a grasper on the tendon so I have traction on it, and I'll release on the superior aspect of the rotator cuff. I'll release the entire coracohumeral ligament, so I skeletonize the coracoid. Then I'll go posteriorly. I'll release all along the spine of the scapula and mobilize that, and then I'll go underneath, and I'll release also the coracohumeral ligament underneath the supraspinatus, and then I'll usually release at the capsulabral junction superiorly and go posteriorly underneath the infraspinatus. And once I've done that, that's usually about all I'll release. I don't do a lot of rotator interval slides. Occasionally, if it's an L-shaped tear and there's adhesions at the coracoid, I'll release it. But for a standard crescent-shaped tear or even other tears, I usually don't do interval slides, because if the tissue's already attached, I don't usually separate it. Some other authors and surgeons have described that, and you can sometimes get a little more mobilization, but I usually don't find that to be necessary.
Thank you.
The other, before we get into anchor placement, there's also bony preparation. How is that, was there something that happened over time that you said, this is really important as well, and we're not putting enough attention there? And then, what do you actually do to prepare?
The bony prep, I think, is an area where there's a lot of opportunity maybe for some innovation, because the tendon healing occurs from the bone up to the tendon as opposed from the tendon down to the bone. So I prepare the tuberosity by removing all the soft tissue, try and get punctate bleeding on the tuberosity surface, and then I will sometimes do marrow stimulation as well. There's some studies out recently which showed maybe it doesn't make as big a difference as we thought, but sometimes the bone is really sclerotic and doesn't bleed very much. And other times it's very soft, so you have to kind of use your judgment on that. If the bone's really soft, I try not to take away too much of the cortex or try not to create a trough or anything like that, because that's going to compromise your anchor fixation. If the bone's really sclerotic, then I try and get a nice bleeding bone surface, and if it's really sclerotic, then I'll also do some marrow stimulation and just to try and get some additional healing that occurs there.
Is this, and how are you doing the marrow stimulation? Are you doing it with like a power pick, or are you doing it,
Yeah, I usually use a motorized pick like that to stimulate it, or you can even just use your punch or whatever. The best bone, if you look at micro CTs, the best bone is right at the articular margin, and then it's about 1.5 centimeters to 2 centimeters lateral. So that's where, ideally you put your anchors. The medial row of anchors, I like a double row technique. If you put medial anchors in, right at the articular margin is usually the best bone, and that usually has really good fixation, and then laterally is the second best place. I personally like to, when I'm putting the anchors in, I like to use a punch because I can get a sense of what the bone quality is. And if it's really soft, I sometimes I'll use a smaller punch so that I can put a standard size anchor in. If I find that it's really soft, you can either go with an upsize anchor, or there's other tricks like cortical augmentation and things you can do to deal with really soft bone. Yeah. But most of the time, if you're careful, meticulous about the surgery, you can use standard anchors.
Mm-hmm. Now, before we get to, you had mentioned double row. We're going to talk about that briefly. But before we get to that, you published an article in OJSM in 2021 titled The Evolution of Arthroscopic Rotator Cuff Repair. And in there, you talked about how anchors have changed over time. And you were talking about anchor purchase and bone. Can you tell our listeners how the anchors have evolved and what your preferred anchor is in terms of really optimizing fixation in the bone?
Yeah, I think that the methods of fixation have changed a lot. Historically, people were using transosseous repairs with open techniques. Then, when the technique became arthroscopic, people were using single row techniques, and there were some higher failure rates using arthroscopic surgery, and it was probably related to the lack of adequate fixation. So then we started looking at ways we could use double row fixation to try and increase the surface area of the repair. J.P. Warner was my partner, did a really important study, I think, that looked at the way that the repair techniques influenced the surface area and the strength of the repairs. And then what we did is I started thinking about this, and we started linking the medial and lateral rows. And as far as I know, one of our papers with looking at that, we called a mattress double anchor technique, was really the first study that showed a bridging type repair construct where the medial and lateral rows were linked. And then you could also do these crisscross configurations, which now has evolved into the modern bridging type repairs, transosseous equivalent, or there's a variety of different names for them. And those repairs dissipated the force over the whole construct. So if you had a patient with poor quality bone, you're spreading the force over all the anchors. If you had a patient with poor quality tendon, you're spreading the load across the whole construct so the tendon wouldn't cut through, rather than having force concentration in one area. Because the weak links were, initially anchors would pull out, or tendon, the sutures would cut through the tendon. But with these bridging constructs, we saw less and less of that. And then the technology evolved so that the anchors were designed specifically so that they were designed to purchase in the cortical bone. The tuberosity is really just like an eggshell in some patients. So you want your best fixation is that cortical rim. So having fully threaded anchors, which some of the companies developed, and then they expanded into having different types of suture material with broader tapes and things like that basically dissipated the force over a larger surface area. So all these things sort of came together and evolved into the modern type of bridging linked double row construct that we are all familiar with today.
Absolutely.
Yeah, I think I know you to be a very humble and kind person, so I don't want to embarrass you. But it's quite, from our perspective, it's quite a legacy to sort of look back and say, I believe you told me once that when you did your fellowship, arthroscopy was not part of it, or not a big part of it.
I didn't do, and I did zero arthroscopic rotator cuff repairs.
Wow. So
I did arthroscopy. Yeah. I'm not that old.
No. I meant for rotator cuff specifically.
But we didn't. I did zero arthroscopic rotator cuff repairs during my fellowship. Yep.
Yeah.
So I had to learn on the fly.
Yeah. So it's pretty. I mean, it's just pretty neat. And again, not to embarrass you, but just to sort of look at a problem like that and say, okay, one, this is a new paradigm, of how to deal with rotator cuff injuries, but then not just like, okay, let's get comfortable with a less invasive technique, but then how to, I'm embarrassing you, I can, but how to make it really great, and to, develop what you did with that bridging technique.
It was kind of scary when I started. Very scary. I could see that people wanted arthroscopic rotator cuff repair, and I knew there were some people that were doing it. Steve Burkhart, Buddy Savoie, Steve Snyder, J.P. Warner, who was my partner, and I had the arthroscopic skills to do arthroscopy of the shoulder, but I didn't have the understanding of how to do it. So I had to learn a lot of it on my own. Fortunately, I did go and visit some of those people and watch their techniques and read all their articles. And then what also happened is, our industry partners innovated as well. We didn't have high-strength sutures, so would get to the end of the repair, you'd tie your last knot, and it would break because it was just a simple Ethibond suture. So I remember the OR staff used to roll their eyes when they'd see an arthroscopic rotator cuff repair on the schedule because it would take a long time. And eventually we refined the technique. Now they're fairly routine and standard, and it's really grown a lot. I remember one of the first articles I published when I went back to Vail from Harvard was on the 10-year outcomes after open rotator cuff repair. And one of the reviewers, we had about 80, in the low 80% survivorship at 10 years, which was what it was at the time. And one of the reviewers sent back a comment saying, why do we need a paper like this? Everyone knows rotator cuff repair works so well. And if you think about it, 80%, is 1 out of 5 patients is not doing well long term.
Right.
And with how common rotator cuff repairs are, that's a lot of patients.
Big number.
And that's why we still talk about how to treat massive tear as a failed tear. But now we've gone back and looked at our 10-year results, after the evolution of all this technology and insights in tear patterns and technical aspects of the surgery. And now we have over 95% success rate at 10-year, a minimum 10-year outcome. So it's a pretty big difference, and it's a big, improvement for our patients that, come in with these problems every day.
It's a lot of attention to detail to, sort of fine tune, as you expressed, just, okay, do I want just a single row? No, okay, we need to do a double row. Now I need to think about, tapes as opposed to Ethibond.
Yeah.
Exactly.
So it's a lot of attention to detail, but it's the technique that most of us use across the country. So it is a pretty.
But it's also, it's a lot of it's the principles that, Dr. Neer talked about, low tension repair, not just eliminating pain, but achieving healing so that you can restore function to the patients. And if you do all those steps, you increase your chances for success pretty dramatically. And most of our patients now do really well. I remember when I was first starting practice and somebody would come into the rotator cuff tear, and I was like terrified that, what's going to happen. I remember some of my friends, particularly Evan Flato, who said never get an MRI on a patient after a rotator cuff repair. Tell them the anchors are going to fly out of the room because they would frequently be read as a persistent defect, a re-tear. But now I'm pretty confident that we can get it, and that we can get a good outcome. So
that's great.
Yeah, you guys know the difference in definition between a re-tear and a failure of healing?
Tell us.
Yes.
I know there's a joke here.
So if you do the surgery yourself the first time, it's a failure of healing. If somebody else has done it, it's a re-tear. So
I love it. I'm going to use that.
That's really great.
time to go off the cuff. We're talking rotator cuff mastery with Dr. Peter Millett from the Steadman Clinic in Vail, Colorado. Dr. Millett has used the Arthrex SpeedBridge double row rotator cuff repair system for over 15 years and has published his 10-year outcomes, highlighting 94% survivorship.
The FiberTech SpeedBridge repair provides the latest in Arthrex suture anchor technology by utilizing small, all-suture FiberTech RC soft anchors medially with self-punching swivel lock anchors laterally. For more complex cases where the patient's biology and potential to heal is a concern, the CuffMend augmentation system can then be used to augment the repair with Arthoflex human dermal allograft or autologous tissue, backed by science and helping to further the Arthrex mission of helping surgeons treat their patients better.
With more than 40 years in minimally invasive surgical technology, Arthrex is a global leader in sports medicine and orthopedic innovations. Head to arthrex.com and orthopedia.com to learn more from the company that's helping surgeons master their practice, including rotator cuff mastery. So you talked about how our success rate has improved. You said mid-90s, 95%, and that has to do with evolution of the implants and tapes and better suture, but also possibly some rotator cuff augmentation as well. So we do want to talk about that aspect of rotator cuff repair.
Yeah, it's a really hot topic right now.
Yeah, so first, how are you deciding? I mean, obviously, we'd love to throw biology at every patient, right? But that's not cost effective. So how are you deciding which patients would benefit from augmentation versus not?
Yeah, for me, the first indication I think for augmentation was for partial thickness tears. And I looked up my own series of partial thickness tears, and we have a very low reoperation rate. So at 10 years, we didn't have any reoperation. So I wasn't sure that was the best first indication for it. I think there are some patients that have partial tears they have good quality tendon, and there's patients who have partial tears who are tendon paths, so that their tendons are just starting to, you're catching them early and their tendons starting to degenerate. And those patients probably would be good candidates, I think, for augmentation. I've used augmentation mostly historically in patients that were having revisions that had a short tendon with healthy muscle, where we could get the tendon over, say, to the medial part of the footprint, but we couldn't really get it over laterally, so we did bridging. More recently, we've been doing, we've done some SCRs as well, and for people that have a persistent defect where it's really a true bridging construct. And now the interesting area is really for augmentation, and I think there's been a lot of innovation and the technique, how to get the graft into the joint arthroscopically, and then how to secure it. And I think that there's going to be an increasing role for that in our rotator cuffs to decrease the re-tear rate even further. The ideal indication, I think, for me is a patient with really poor quality tendon after a sufficient, you've done everything you can and you've gotten as good an anatomic repair as you can, and you still think the tendon quality is not good. And that's still, I think, qualitative. It's not, there's not for me a quantitative number which I lay my hat. Some people look at the ROHI score and look at that a little bit and try and use that. For me, it's still sort of qualitative. After I've done my best, is a tendon of sufficient quality that it's going to hold the sutures and not pull off, or is it something that's a little bit thinner, more deficient tendon, more pathologic tissue that you want to add some additional biology to it?
That makes sense.
Yeah. So now on to, as you know, one of my favorite post-op rehab.
Oh, I love this.
I don't know if you remember. Do you remember the first time I ever reached out to you?
I do.
Okay. So I was still a PT in Boston.
Yes.
And wow. I still remember, I don't think I told you this. Recently, I found my old Hotmail password, my hotmail.com. And so
nice.
It's still active. And I saw all these, even just the side folders of all these things, like trying to get into med school. Or it was wild to sort of look at all this old correspondence.
I remember when you came to visit. I was in my little tiny office, and you came and visited. And
it was before, all the build out.
Yeah.
So
before
funny.
remodeled and everything. Yeah.
But anyway, long time ago.
We go way back.
Yeah.
Yes.
So rehab-wise, I think and I've told Ashley about this before, one of the really great things about the Steadman Clinic is the integration with rehab, how close it is, how you have like a dedicated therapist who's really just like, manning the ship and sort of saying, this is, how Dr. Millett likes his rehab to go and knows all the nuance and is familiar with the OR and, you're rounding together. So it's super unique. But as far as, things we've learned in rehab over the years, starting super conservative, don't get them out of the sling at all, and then they're all getting really stiff. And then sometimes people are getting too far on the other side of the spectrum. Where have you landed more recently?
Well, I think when we started doing arthroscopic cuff repairs, there was a big push towards going very slowly because I think everyone was concerned about the strength of the repair. But what I've learned is that we've optimized the mechanics of the repair. So, and we know that if you totally offload a tendon, that's not good for healing. If there were some studies that looked at applying Botox to rats and things, and it showed that the tendons didn't heal that well. So some loading is good, and I think an appropriate amount of loading that the tear can withstand and the repair can withstand is a good thing. So we're fairly aggressive, I would say, in the spectrum of things, or appropriate. And we do work very closely with our therapists, so I think that's helpful, so that we're blessed in that we have a fairly healthy patient population, and we have motivated patients, and we have good quality therapy. So I think in those instances we can be a little bit more aggressive so that it accelerates the recovery for the patient. Patients don't want to be tied up for 6 months or 9 months or 12 months after rotator cuff repair. And we've looked at our results in a series of over 500 cases, and the average return to full activities was 3.5 to 4 months, where they were cleared for full activities. Whereas when I was in my training and first starting out, it was 6 to 12 months probably was more of the standard. So we've now hastened recovery. Patients, want to be fixed, but they also want to get better quickly. So if you can shorten sling use, you can allow them to get back to their activities more quickly. I think those are all good things. So if it's a standard repair, we'll typically let them, start moving it right away, keep them in a sling for a few weeks. 3 to 4 is probably typical for a standard crescent repair that's really solid, and then start active motion at that point. And that seems to be getting shorter and shorter, every 5 years or so. And maybe there's something we can do biologically to even accelerate that further. But most of our patients are using a sling for about a month, and then starting active motion, starting strengthening at that point, and then around 3.5 to 4 months are kind of getting cleared for golf or tennis or whatever sports they want to get back to.
Yeah, it's exciting.
It is. So you mentioned patient outcomes, and we kind of talked about how they've improved. You published a paper in AJSM in 2020 looking at predictive modeling to kind of predict which patients would do well and which patients maybe have a lower chance of doing well, and maybe you want to counsel them a bit more. Can you talk a little bit about that in terms of maybe some risk factors and how you counsel patients about what to expect post-operatively in terms of their recovery?
Yeah, I think that's one thing we've gotten really a lot better at is our patient selection. Certainly there's patients that have massive tears that you're probably not going to be able to repair. If you do, it's going to be a tenuous repair. So you can lay some crepe ahead of time. So the things that I worry about are revisions, obviously. Work comp always seems to come out as a confounding variable that is a negative prognostic indicator. Age was something that was always historically thought of as a negative predictor, but we've looked at our series of patients who have been older than 70, and if they have good quality tissue, they tend to do just as well as young patients. So that's something that it's a relative consideration for me, just as anybody who's a little bit older, you worry about them healing, but if they have good quality tissue and they're active, they usually will do very well with an arthroscopic cuff repair. So that's changed over time. I remember people not recommending surgery to those patients or recommending that they have a reverse shoulder replacement or something else. But if you can repair it and they have good quality tissue, I think that's still only maybe a relative consideration. Smokers, obviously people who have significant comorbidities are always things to consider, but the main thing I would say is really the tissue quality that you can see from your physical exam, how much atrophy they have. Do they have, what's the size of the tear? Is it a massive tear with a big lag sign, or is it a tear that's retracted but still mobile? When you start to see atrophy on their physical exam, and then when you see, advanced fatty infiltration and atrophy on the MRI, then those are the ones I'm a little more concerned that we can't we won't be able to get as good a repair.
That makes sense.
Yeah, and you'd briefly mentioned adding some biology or anything to speed up the repair. Is there anything that you sort of see on the forefront that you're excited about?
Mm-hmm.
I mean, there's a lot of interesting, new studies which are out there looking at reactive oxygen species, antifibrotics, stem cells. Other types of growth factors. People have looked at BMAC. People have looked at PRP. We use a PRP in most of our patients with rotator cuff tears. But I think there's still a lot of opportunity to improve healing. I think maybe getting some improvement in the muscle quality will be a big thing, because I think once the fatty infiltration occurs and the severe atrophy occurs in the muscle, kind of the horse is out of the barn a little bit then. And if we can reverse that, I don't know whether it's with stem cells or it's with gene editing or whatever it is, that I think will be a big evolution and allow us for more reconstructive options down the road.
Yeah, agree.
Well, that's a really positive note
Yeah,
to end
I
on.
know.
Right? That's the best thing about sports medicine, right? It just keeps advancing. 10 years from now, we're going to be using a whole bunch of different things we don't even have today. So really excited to see where we go from here, especially with the biologics. So
Me too.
well, thank you so much for taking
Thanks,
the time
We're
to
so
be here with us.
appreciative.
Yeah.
Thanks,
yeah,
Catherine.
truly.
Yeah, it's great to be
Yeah.
here with you.
Yeah, no,
Awesome.
thank you.
Thank you.
Thank you.
Thank you for listening to this episode of the Sports Docs podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love hearing from you.